Hi, my name is Jerry Hesch, and I'm a physical therapist, and I'm the developer of the Hesch method of treating the SI joint and the pelvis. I got an inquiry. I belong to a list-serve group, and I'm going to read you these questions. I'm going to respond primarily to the question of upslip of the ilium. So let me read you just a couple sentences in this inquiry. I currently have a patient who is having her second child, and she is 25 weeks along now. She has referred to me for low back pain. With palpation, she does appear to have a left upslip, and on palpation has tenderness over the left posterior hip region and the left iliac crest. SI compression and distraction both provoke symptoms, but in the posterior hip SI region and hip scour is positive, with pain in the posterior lateral hip. She occasionally has radicular pain down the left posterior thigh. I performed the muscle energy technique for a left upslip and made her pain worse, both during and after the techniques. I am questioning whether it is her hip or her SI region. I have done some hip capsule and piriformis stretches, and these also made her pain worse. Today I issued an SI belt for her and began some hip strengthening and core stabilization exercises. Any ideas for me? Question mark. I've heard that pain can refer to the buttock due to the uterine ligaments. Does this sound feasible? Also, is it possibly a bursitis? And I'm going to ignore the last two questions. I'm not going to have time because I'm going to be focusing on the question of upslip, and there are others who can speak much more intelligently than myself on the innervation of the uterine ligaments and their pain referral pattern. And, standard orthopedic text will tell you how to screen for a hip bursitis, which she, may have, although I think it's a little early to ask that question. I think we need to make sure that the pelvic structures are balanced as well as the soft tissue structures around it, and then screen for it. That's my personal bias. All right, could she have an upslip? Let's talk about that. By definition, an upslip of the ilium is speaking of not a muscular pattern of the pelvis, but by definition is actually a true vertical fixation of the ilium in relationship to the sacrum. Now, some of the literature tells you that when you have an upslip there, that you also have an upslip at the symphysis pubis. Now, I have screened this for many, many years, and I would say that categorically that is false, that it is unusual and rare to actually have a coexisting vertical slip at the symphysis pubis. Now, you can have the pelvis disoriented in space where it looks like this is higher if you're looking for symmetry, but if you walk across it, you will find there is no step off. If there was a true upslip at the symphysis pubis, you would absolutely feel a step off, and certainly an AP film of the pelvis should reveal that as well. But let's come back to upslip. In upslip, people will say that the iliac crest is higher on that side. We're going to stay on the left side. And they will say that the ischial tuberosity also appears higher. Now, there are a couple of false positives that can cause simple side bending of the pelvis or elevation on that side with nothing going on within the joint itself. So we need to rule that out. There is very poor intertester reliability with iliac crest palpation, and the first research project on that was in 1985 in PT Journal, and there have been several others since. The good news is that rather than using this elusive iliac crest, we can use two additional landmarks, and the research is very supportive of that in terms of utility and intertester reliability. Those landmarks are not, the traditional landmarks, of course, would be the ASIS and the PSIS and the ischial tuberosity. But right above the ASIS is a rather flat section. It's about 1.5 inches to 2 inches long, and that is called the anterior iliac shelf. Posteriorly, at about the midline, is perhaps part of what people call the shelf. But in truth, the highest portion in a typical pelvis is actually back here, not out here, laterally. This portion I have named the posterior iliac shelf. And it is a flat portion, like that. And it is in the middle. So here's midline of the spine and the sacrum. Here's the lateral mass of the pelvis. And in most cases, this is right in the middle. Now, in this anatomical specimen, I need to bring it back a little bit because it would appear that the rear of the SI was really malpositioned. So you can see that it would be in a real person approximately at the midline. I hope that makes sense. When I palpate it, I use extended digits. The client is lying prone. Let me make a little bit of room. We'll use this model. And in this model, you can see a little bit better that in fact, this portion, which is the flat portion, which I call the posterior iliac shelf, is in fact approximately in the very middle, and the palpation is done like this. So let's imagine that we have a client, and all of these landmarks are superior. So you have to make a decision. Is this an upslip, or is this a muscle pattern? I submit to you it could also be a downslip. Now, most people would say, what? That doesn't make any sense. How could something look like it is an upslip and yet it is a downslip? It's a very relevant question, particularly when the treatment for upslip increased her pain. How is that possible? If someone has a true downslip, and these are very rare, but if they have a downslip, they probably have a more planar type SI joint with less stability on that side. For whatever reason or whatever injury, the ilium slides inferiorly in relationship to the sacrum and it gets stuck there. It will traction the sciatic nerve. And I had a real human specimen that I gave away, but in the top, the roof of the greater sciatic notch, I could cut meat with it. It was very sharp. So that coming down would alter the dimensions there where the sciatic nerve comes through. Piriformis muscle crosses, is, a couple of ligaments, we could elaborate later, but basically you would have a compressive force on the sciatic notch coming down from the top and probably altered tension, which we could elaborate on later, but point being, sciatic nerve is going to get irritated with that. And people with a true downslip have kind of a queasy, really unpleasant type of sciatica. May not reach below the, into the lower leg, or it may, it depends. But it's a very, very unpleasant type of a dysfunction. So, all landmarks look like it's a downslip, but the secondary stabilizers kick in, such as the quadratus lumborum and the obliques, and they actually, you have a true downslip, but then the pelvis side bends because these muscles are trying to bring it up, that they can't. They're not the correct angle, the correct amount of force, correct amount, to move that ilium up. So the best they can do is just, side bend the pelvis on that side. So that's how you can have a true downslip and it looks like an upslip. Okay? Now, there's some other tests that can be much more helpful than simple palpation and appearance. And we have an oblique ligament here called the sacrotuberous. It goes from the lower sacrum, part of the coccyx, and it goes obliquely, approximately a 30 to 45 degree angle and attaches on the ischial tuberosity. And that's called the sacrotuberous ligament. It is extremely easy to find, okay? And you can compare the tone on this thing side to side. There's nothing here that is bony, okay? But when you palpate in this neighborhood and you feel something that feels like a rock, that in fact is the sacrotuberous ligament, okay? So it's easy to find. What you do is you make a triangle and you look for the gluteal cleft. This would be the top of the gluteal cleft here. And coccyx is here. Bottom of the ischial tuberosity is here. And you make a little triangle like that. And right there defines a little bit deeper, because you have to go through the gluteals. That in fact is where the sacrotuberous ligament is. We're going to stop filming in a very short while because we're running out of time, and we hope to post this on YouTube, which is limited to 10 minutes. But right here, you can see the bottom of the ischium. Gluteal cleft would be about here. You could create that triangle, and here's a picture with the muscles not removed, and that the fibers of the glute duplicate the direction of the fibers, ischial tuberosity being right here. Thank you. Please see part 2 of this video. Thank you. Yeah.